not everyone, but the vast majority of people with ADHD, the problem started in childhood, usually before the age of 12. It may be that you can't organize yourself, or you're constantly late, or you struggle to focus your attention in something that you really want to do. So that's the interesting thing. It's not that people are lazy or they don't want to do something. Sometimes they really want to do something and they still can't.
Hello and welcome back to another episode of The Health Review. I'm your host, Emily Rose Adams. Now, today's conversation is one I'm so excited to share with you. I'm joined by Dr. Jorge Zimbron, a consultant psychiatrist and the clinical lead at Springbank Ward in Cambridge, a specialist unit dedicated to supporting women with complex mental health needs and a diagnosis of personality disorder. In addition to his work at Springbank, Jorge is also the director of Cambridge Psychiatry. And in the second half of our conversation, we dive into a topic that's been getting a lot of attention, ADHD. We explore whether we're seeing a true rise in cases, how it's diagnosed, and the treatment options available. Jorge shares some incredibly helpful advice for anyone who might be experiencing symptoms or wondering if they should seek support. Oh, and one more thing, Jorge also happens to be my brother-in-law. So this was a really informative chat with someone I know very well and who brings both compassion and clarity to some big mental health topics. So let's get into it. Please welcome Dr. Jorge Zimbron to the Health Review.
Jorge, thank you so much for coming on. It's great to have you here with us. And we've had a bit of a family affair on this podcast. So we've had Dr. Rimal Sheikh, who's your wife.
Yep.
Very lucky to have you as my brother-in-law. It's also going to be great to just hear about what you do on a daily basis. Really inspirational and important work. But first, I'd just love to know why you went into psychiatry. Like, was there a specific moment or a kind of reflection that you had where you thought, this is the line of work that I want to pursue?
Sure. I think that it's a journey like everything else. It's first you kind of get into why do you want to do medicine? Yeah, something inspires you to do medicine. Then you land in a particular specialty, and then you land on a subspecialty for me. I think the first thing that happened was, I suppose, throughout all of it, fear is a really strong motivator, strangely. So it's not that I spent a lot of time thinking and considering things. There were certain episodes and events that happened that suddenly I just thought, yeah, of course I have to do that. So, yeah, I think I was 14, and there was a sister of a friend died in some sort of in a lab accident because someone couldn't do a medical procedure. And I mean, I wasn't particularly close or anything, but I just thought in that moment, I wouldn't want to be in a position where I couldn't help someone if they were having an emergency or a problem. I should do medicine. And that was it, right? It wasn't, I don't regret it at all, but it certainly wasn't that thought through. And I do come from a line of doctors, so on my dad's side, the vast majority of the family are doctors. So growing up, I thought, I don't want to be a doctor because everyone else is a doctor. But then in that moment, it just made sense. And after that, there was a problem with a friend and his parents and how they related. And there was a sort of situation where he was being quite mean to his parents. And again, it was just a thing like, I just want to try and understand that. So psychiatry is really interesting to anyone that goes into medicine. Everyone says it's very interesting. But then, yeah, after that particular episode, I thought I really should try and understand people and behavior better. And then after that, once you get into psychiatry, then one of the things that I struggled with was there are a certain group of patients that all psychiatrists and mental health professionals struggle with, and they find it difficult to manage. And so normally this is called personality disorders, but it can be a wider spectrum of neurodivergent conditions that just people that just don't quite fit in the books and don't quite fit in the algorithm that you want to try. And so I just, again, fear, right? So you're scared that you're going to be there, you're going to become a consultant, you don't know how to manage this. So I thought I'll go and choose a placement specifically on the personality disorder service, thinking it would be a temporary thing. And now I've been in the same job for the last 10 years. But
And that sort of, I guess, takes us to, yes, Springbank, where you work. You've got your NHS job. You also have a private clinic as well. So you're seeing sort of both sides of it. But you're seeing patients who are maybe not doing too well at other clinics across the country, and they're coming to you. And you're doing things quite a bit differently there. You're doing different treatments and therapies than perhaps these patients were receiving at other clinics, and you're getting great results. What do those treatments look like?
yeah, so at Springbank we get a range of people being referred from all over the country. Springbank is a specialist personality disorder unit, and in practice what that means is that people that have tried services within their area and they have not gotten better, or people who have done something very, very risky. It's usually risk to themselves, so they've done something to hurt themselves that is very serious, or have been doing that persistently. It's an interesting thing to think about. How does society deal with a group of people that you're trying to help, but they seem not to want help or seem to be getting worse? So fear, again, is the motivating thing here. What normally happens is that people get scared, and so they will try and manage that risk by putting restrictions on someone. So if you are suicidal, and sometimes, emergency services come in contact with you, they might try and put you in the hospital to keep you safe. So the idea is that you will be safe there. And sometimes you don't want to be in a hospital, so then they'll put you under a section of the Mental Health Act, which forces you to be there against your will. And the idea there is that you're trying to keep someone safe and prevent that risk. So the general way of dealing with people who are chronically suicidal in the UK is to try and put those restrictions in place. The problem is that when you do that, it helps people feel better in the moment. So if you're a paramedic or a police officer or a doctor dealing with someone right there and then, you'll feel better if you think, oh, I can put them somewhere. And the family will be happier. This affects families as well. So they'll be happier if they just put you somewhere and you stay there and that's it. The problem is that's not the end of the story. The story continues. And actually, when you put restrictions around someone, it's not difficult to understand that if they take away your possessions, they take away your freedom, you will get worse.
Mm-hmm.
So at Springbank, we take a very different approach in that we offer therapy. It's very simple. We offer therapy, but we don't enforce therapy. And we prepare people to come in and understand that. And you don't only have to explain that to the patients, but you also have to explain that to parents and to families. So what happens typically is that these people have been in restrictive environments for years.
Mm-hmm.
So you would have someone who has been under a section of the Mental Health Act in an acute ward for years. I've had people for 7 years detained, quite often on 1-to-1 or 2-to-1 observations. What that means is there's someone with them, sitting with them at all times, sometimes even if they're in the toilet or in the shower. And then again, the idea is that you're going to prevent suicide by doing that. And then they come to Springbank, and on usually day one, the section gets lifted. They're never on 1-to-1 observations, and there is no more restrictions. They can go out of the ward if they want to, and we will not stop them. We will try and talk them out of it if they're thinking of doing something, but we will not stop them. And this is explained, and there's a way of doing this, but what happens is that you sometimes see dramatic changes on day one, right? So this is not the application of a therapy, is the application of a different environment and a different way of approaching a problem. So we've had very good results, and I think it's an important thing to raise awareness of, because in the UK and in other developed countries as well, the way that this problem is managed is through restrictive practices. And the reason is because we are afraid of the consequences, someone dying. The media, we're afraid that someone's going to die and we're going to be exposed in the media, or the coroner, we're going to be found negligent for not helping someone. But the consequences of that is that we are very restrictive with a significant group of people, which is a minority, but still it's a significant group of people that are not benefiting from the way that services are designed. And this is a debate that we need to have as a society and think about, because we're not providing an environment that's suitable for the vast majority of these patients.
So I guess it takes a lot of courage from yourself and your team to have the confidence to adapt that kind of style of treatment, but at the same time you're giving your patients independence and their identity, and that, I guess that's so important, especially if they're going through an episode or a crisis like that, to still feel like they have an element of control. I'm guessing is hugely important. And I know a lot of your patients are coming to you perhaps already with a diagnosis of borderline personality disorder. Can you just explain what that is?
Yeah, the diagnosis is a controversial diagnosis. It's been around for a while, but effectively the term personality disorder, the 3 Ps are an easy way of explaining it. Mind, the charity uses this, is that it's about behavior, and the behavior is pervasive, so it affects all sorts of areas in your life. It is persistent, right? So you keep doing this behavior, whatever it is, and it is problematic. It's causing you problems in your life. So in terms of borderline personality disorder, people, the most significant thing that attracts other people's attention is a self-destructive behavior. And it can be through either self-harm, suicide attempts, but also impulsivity, things like getting into relationships that are not good for you. There's quite a lot of emotional instability, so huge ups and downs that seem out of proportion with whatever happens. There's an element of fear of abandonment. There's very intense relationships that then lead to breakups, and then the people then feel very suicidal. There is a feeling of emptiness quite often, that people report a feeling of feeling empty. But there are also problems with identity, of not knowing who they are or what they like. And there are huge overlaps with other diagnoses. So you recognize those other those characteristics from other diagnoses, such as neurodiversity diagnoses like ASD, autistic spectrum disorder, or ADHD. So typically what we find is that it's not that you get a pure textbook case that only has borderline personality disorder. What we tend to see in the people that we look after is someone who comes in who would meet criteria for a number of different diagnoses and are complex, but that tends to be the norm rather than the exception.
Mm-hmm. And I was reading that the type of therapy you use, dialectical behavioral therapy.
Yeah, so dialectic behavior therapy is form of talking therapy that was developed by Marcia Linehan in the US. Later, she disclosed that she also suffers from borderline personality disorder herself, and it's a complex therapy that involves having one-to-one therapy once a week, and then also a group therapy once a week, and this runs ideally for a year, which is what we do. And so in a group setting, you are teaching skills, and in the one-to-one therapy, you are coaching that person to apply those skills. And there's a range of tools that you use, but what you're trying to do is try and teach skills that are based on emotion regulation. So you're trying to teach people to regulate their emotions better. You're also trying to allow them to tolerate distress, so distress tolerance skills, and also trying to improve their interpersonal skills. So you're looking at emotion regulation, distress tolerance, and interpersonal effectiveness. And there's another component that we use, which is mindfulness. So you're trying to get people, rather than reacting to whatever emotion they're feeling very impulsively, you're trying to make sure that they can use mindfulness to slow down, consider options, and then act in a more effective way. It is time consuming, it's quite resource intensive, but it is very effective. However, what I would say is that it's important to consider not only the type of therapy that you use, such as DBT, there are other therapies, but the environment in which you use them. So we used to have DBT therapy when we were more at a restrictive ward, and it was not very effective because you can't force people to have psychotherapy. You can't force people into this. It's not helpful.
And it takes an element of opening up as well and feeling safe and comfortable. And I guess if you're in a restrictive sort of area, you don't feel that you probably want to be vulnerable like that.
Yeah, correct. I think quite often what it becomes, and I think it's understandable, is that once you're being restricted by someone, part of the challenge is to then overcome that restriction or try and fight the system, which is quite understandable. So what we're trying to do is that we're not here to fight you. We're part of your team. You're here to hopefully get better, and we can try and help. But we're on the same team, right? So it's not me imposing something on you. And that is a huge shift from saying you're here because you have to be here, even if you don't want to, and we're going to provide you with this therapy, whether you like it or not. Then it doesn't matter what therapy you use, it's just not going to be effective.
That's amazing. And what are the results of this? So I know you've had some huge success stories. You've had even some of your ex-patients working with you.
Yeah.
So what are some of those success stories that you can share?
There are quite a few, and that's what keeps us going. It's very hard work for the patients. They are amazing, very resilient people. You have to understand that many of these people have had very difficult childhoods. They've been growing up in very difficult families and difficult environments, and they still manage to thrive, which is amazing to see in the right environment. So yeah, I mean, I think one of our patients has worked with us and then left, but we've had other patients that also have taken up jobs within the same trust as nurses or other trusts. We've just had a patient that we discharged who's going to university to become a paramedic. And I suppose that, it's important to understand this in the context of what you're seeing. So you're seeing people that have been hospitalized for years, chronically suicidal, who are not functioning at all, then starting to work, go to university, and get a life, as we term it, worth living, right? So that they feel that they want to continue living this life. And then we've also had situations where a patient leaves because not everything is easy and not everything works out. So about a third of the patients that we see will not finish the 1-year program. They'll leave early. Sometimes because they've not benefited at all, and sometimes because they just don't want to be in hospital for that long anymore. But sometimes we see people that have perhaps left angry and saying, I don't want to be here anymore, I don't like this. That years later, then you get an email saying, oh, by the way, it was actually helpful, it did help me, thanks for getting me out of hospital, and now I'm doing much better, and I'm working, and I'm in a relationship, etc. So over time, it takes a long time. I think that's the important thing to note. It takes a long time, but you do see some really good results.
And you've been in this industry a long time, and as I mentioned, you're working on the ward, but you've also got your private clinic as well. What are some of the most common sort of mental health symptoms that you're seeing, and how has it sort of evolved?
Interestingly enough, I tend to see quite often a lot of people that are having the same symptoms and problems than the people I see in hospital, which is not what I expected. Quite often I think everyone could benefit from some lifestyle changes. I think that is for sure. But there are very severe problems that people are now coming into clinic, sadly, because the NHS provision is, although full of excellent professionals, not enough. The demand is huge. So you tend to see things that you would have expect and sometimes have to refer to hospital or to a more intense level of treatment. And typically people have been trying to get that level of support, but haven't managed to do that in the NHS. And then they decide, you know what, enough is enough. I'm going to invest my resources in trying to seek help.
Is that concerning for you that perhaps there just isn't the infrastructure in place?
I think it is concerning in the sense that we, as a population, have to know what to expect. So if you are aware that the system in which you live in will not provide healthcare, for example, then you would adapt to try and save some money, perhaps for when you need it, because you get ill, right? So if your mentality is that you're going to get ill, and then the NHS will look after you, then you're not going to make provisions for that. You're not going to save money. You're not going to. So I think at the moment there is a slight problem in that we think that the NHS should look after everyone and everything for free. And then unfortunately, sometimes when it's your turn to be ill, you might not find that sort of resource that you thought was available, and you haven't prepared necessarily for it either. So I think that is concerning.
Sorry to interrupt. If you're enjoying today's episode, please do subscribe or give it a follow so we can keep giving you excellent content and bringing on amazing guests that hopefully you're loving on the Health Review podcast. Now back to the show. I'm curious to get your views on ADHD. I'm not sure how many patients are coming to your private clinic showing symptoms, but it feels like there has been a real rise. I don't know if it's just that people are being more open. You know, there's a lot more talk about it on social media, and experts are speaking about some of the signs and symptoms. But it feels like from sort of when I was a child in the 90s, perhaps you'd get one child in every class where they were medicated and they were being treated and they clearly had symptoms. But now it feels like, you know, you could be in a workplace and half of your peers some people will flippantly say, oh yeah, I've got ADHD, I'm sure of it. But some people are getting, you know, a diagnosis. Do you think it's on the rise, or is it maybe just there's more awareness now?
I think it's probably both. And I think sadly it's difficult to know. So the first thing is to understand that ADHD is a bit of a spectrum as well. So we think, based on the population studies that we've carried out, that in children you get about 5% of children with ADHD. So if you go out and do a population survey and you take questionnaires and you take people trained in detecting ADHD and you sort them out randomly in the country, they'll find that about 5% of children they interview will meet ADHD diagnosis. And if you look at adults, it's about 3 to 4% in the UK. Now, if you look at the US, you get about 10% of children, right? So then comes the questions: is this real? Is this not real? Are we seeing a massive rise in ADHD in the UK? Is this happening? And I suppose that you have to take some of this news reports with a bit of context. So, for example, what we've seen is news saying that the prescription of ADHD medication is on the rise. It's going high. You know, everyone's on ADHD medication, right? So you do have to kind of look at the numbers. What are the numbers? So in the UK, I think 2022-23, the estimate was 278,000 people have ADHD medication prescribed in the UK. So that's about 0.5% of the population. So we've said you're expecting ADHD prevalences of 3 to 4% in adults and 5% in children. So even if you double that amount of medication, you're still just hitting about 1% of prescriptions. So there is a huge level of under-reporting and under-treatment of ADHD, despite it looking like half of your colleagues have it. If you look closely, it's not really half of your colleagues, or it might be more. The creative industries may have a little bit more of a...
Yeah, I feel bad for some of my colleagues now saying that. I just feel like it's not a buzzword, but I don't know if it's that spectrum perhaps. But if you can't finish a book and you're inclined to scroll through TikTok, you like short form videos. Like, does that mean that you have ADHD, or does that just mean that perhaps your attention span isn't as good, and maybe there are lifestyle things that could help?
So again, I think it's important to define what ADHD is, right? So we know that there are, as we diagnose it, 9 symptoms of inattention and 9 symptoms of hyperactivity. So there's something to do with inattention, concentration problems, and hyperactivity, right? But you also have to take into account that those symptoms cause a dysfunction in your life in several areas, right? Not just one, or just you're having several areas of your life that are not functioning well. And the thing is that even though it's trying to be a hard definition, can change, because you can see that, for example, in different stages of your life, that quotes dysfunction will change. So, for example, one thing I'm seeing a lot in my private practice, which, to answer your question before, I am seeing a lot of ADHD in the private practice. We advertise ourselves as general adult psychiatry, but one of the predominant things that we are getting is queries about whether people have ADHD. So what we're seeing is that there is, for example, someone who grows up in reasonably good family environment with very structured parents that provide support, education, etc. And there are some symptoms there in childhood, perhaps not reading a book all the way through, or not paying attention to detail, teachers commenting that perhaps they're talking too much in class, but never get into trouble. They just kind of sail through it. Often quite intelligent children that just get through things without much revision, doing homework maybe last minute. But then they go to university, and then suddenly there's no parents, there's no structure, it's all up to them, no one's going to feed them, and the whole thing collapses, right? So what would not have been defined as ADHD in that childhood environment has now become ADHD in an adult environment where the person can't cope. Then they might meet someone, another half partner, who takes on the parental role and starts sorting out quite a lot of their life and structure, etc. And suddenly they're not as dysfunctional anymore, and they can get on through life. And then that might just no longer be a problem. Then they might break up in that relationship, and suddenly we're in ADHD again. So I suppose there is a proportion of people that have a lot of these symptoms, and whether or not your level of dysfunction will be clinically significant will vary depending according to your circumstances in life. So that changes.
And if someone were to want to go on medication, sort of how severe on that spectrum? Are there people where you'd say, I think you could make some changes with your diet, or are you sleeping, caffeine, things like that? We know that kind of make these symptoms worse. What symptoms would they have to be displaying to get on medication to actually help? That's
a very personal question, and it will vary between different people. And it depends on whether they perceive themselves as that dysfunction. I don't think, there is no objective measure that you can say, yeah, definitely we can, in the milder side. So there's a spectrum. So in the severe end of the spectrum, you can see someone who struggles to pay attention whilst driving, has car accidents, huge emotional instability. And you can very easily see, yeah, that's an issue. But there are milder aspects of that spectrum, in which, for example, people say, I just can't be present with my children, or I can't quite be present with because when I'm talking to my wife or my children, my brain's somewhere else. I'm racing, and I can't sleep very well. And at work, I'm getting into trouble for being late, etc. So this person is, in a relationship, and they are functioning to a degree, and they have a job, but they can see that it's not quite right. And then suddenly they start medication, and it's not like that for everyone. And I can't predict who's going to. About 90% of people respond well to medication, but there are certain individuals who will tell you, and I have not heard this with any other psychiatric medication, life-changing. That they come again and again with saying, this is life-changing. And then you can't really argue with that. Even though they were perhaps functioning reasonably well before, now they're telling you there's something else that is life-changing. And what are the risks of that? What are the risks of them taking that medication? Actually, it's pretty safe. The medication on the whole is pretty safe. There's been studies looking at Cardiovascular risk is the main thing. People worry about your blood pressure going up, getting more strokes, getting more heart attacks, getting more problems. And actually, there is possibly a link with a slight increase in risk.
Mm-hmm.
The baseline risk is low, and the increase in risk is not very high either.
Mm-hmm.
So for the people that are saying, yes, this drug is life-changing, most of them will be perfectly happy with that risk. So you explain the risk when you're about to start. And the people that take the medication and the benefit is not that great, they stop. So generally, what we see is, surprisingly, about 4 out of 5 people, 5 years down the line, stop it.
Really?
Yeah.
That's so interesting.
Yeah.
And they, after they come off, they
might come back to it again. Again, it's this kind of fluctuation in severity and circumstances in life. But it's not, again, it's you're talking about a small percentage of the population, 3 to 4%. And then out of that percentage, there will be people that will need that medication consistently and will take it consistently. But actually, the majority don't. They will start it. Maybe it's effective for a period of time. Maybe during their exams or during a particularly academic period that needed a lot of organizational skills and thinking and concentrating. And then life changes, and perhaps they just don't see that it's necessary anymore. So these things fluctuate.
And I guess for you, like, a huge part of it will be finding out, the details of their day-to-day lives and their story. And, I guess that for you is like a huge part of the consideration that you'll be thinking about as to whether they take medication or not. It's like,
Correct.
Is this a temporary thing? Is this a lifestyle thing that you're doing? I'm curious to know, is there a link between ADHD and perhaps like addiction stuff? So if you are struggling with ADHD symptoms, are you more likely to self-medicate with alcohol or drugs to kind of relax your mind or focus your...
Yeah, that's extremely common as well. So quite often people say that they, quotes, self-medicate. So people with ADHD tend to take a lot of caffeine, for example. That sometimes helps, because caffeine is a stimulant. The other thing that tends to happen is that they see that alcohol can be helpful. What they describe is these racing thoughts that they have at night, and they just can't sleep. So I had this particular patient who had an alcohol problem, but it's an atypical alcohol problem. So he would drink, but he wouldn't go out and drink with his friends. He would sometimes just drink by himself. And it was not to do with anything other than trying to quiet the thoughts down. The problem is, once that started, then he would get into trouble because of all the alcohol-related problems that you can land yourself in. It's a way of trying to manage, and drugs sometimes do the same. What you tend to see when you start people on treatment is that goes down. So their alcohol drinking goes down, their drug dependence goes down. It might not completely solve it, but you do see a reduction in not only alcohol and drugs, but you also see a reduction in things like car accidents, motor vehicle accidents, and things like that.
I've never thought about car accidents. That's really scary, isn't it? That could actually lead to having a potentially catastrophic incident.
Yeah. So I think we have to balance the benefit of these medications against the risks of taking these medications. And yes, perhaps if your risk is 30% higher of getting a stroke 20 years down the line, that is a consideration. But you have to balance that against the risk of crashing your car or landing yourself in all sorts of trouble. So I think the risk-benefit analysis for me is very clear that these medications can be quite helpful. And they're not... I suppose there's an element of people thinking that this is about you trying to get an edge over people and, taking this medication to do that project or pass that exam or do that. They don't really work as well as a sort of enhancer. So if your brain is okay and you're reasonably able to focus and you're reasonably able to, they don't necessarily help you, and they might just make things worse. So people that take it and benefit and make and feel that this is life-changing, they know that this is a complete game changer for them. That doesn't mean that it will help everyone. It just helps a proportion of people. And I think, sadly, the barriers to it to get that medication are quite high. There's quite a lot of, you have to create a very detailed assessment of the person, and then you have to see a professional and get parents to contribute and try and get school reports, etc. It's a very resource-intensive exercise, and therefore that's why we're seeing only a fraction of the population that have ADHD being treated for ADHD.
Which is a shame, really, because I think, we've got to the point now where perhaps there's more awareness, but we don't have the system in place to actually help all those people who may be on the spectrum somewhere. For people who might be listening now and are struggling, have a suspicion they could have ADHD but aren't really sure, what are some of the main red flags that you recognize that perhaps could lead someone to sort of think, right, I need to go and speak to a doctor now?
I guess that if you've been struggling with a problem for a very long period of time, not everyone, but the vast majority of people with ADHD, the problem started in childhood, usually before the age of 12. So usually we think between the ages of 5 and 12, something started. So you can see that there's a particular pattern that has been present for a very long time. Whatever it is, it may be that you can't organize yourself, or you're constantly late, or you struggle to focus your attention in something that you really want to do. So that's the interesting thing. It's like, it's not that people are lazy or they don't want to do something. Sometimes they really want to do something and they still can't. So if you're having that sort of level of trouble and is now having an impact in your life, just read about it. People that generally have ADHD will read about it and just think, yeah, that's me, right? So there's plenty of information out there. You read about it, and then you go and see a doctor and talk about it. The trouble is obviously accessing the treatment, and that's going to be hard at the moment within an NHS system.
And in terms of, I guess specifically to ADHD, lifestyle changes you can make, are there any sort of top few things you can do?
So people learn over time to do certain things. Quite simply, for example, having a very clear structure in your house where you put things, right? So your phone always goes in one place and your keys always go in one place. The trouble, of course, is that people with ADHD often are very bad at doing that. But if you can structure yourself to say, this is the bowl for the keys, and every time I'll just put the keys there, then they struggle quite often with losing things. And that's a big thing, losing phones, getting out of the house, always being late because you've lost something, you have to go back to the house. So having a system helps. Trying to have some system that is consistent helps. Exercise helps hugely. So quite often, one thing that you see is that someone who was having symptoms of ADHD but functioning in childhood or younger years, for whatever reason, stops being able to exercise. And then the whole thing unravels and things get much worse. So exercising, quite often fairly intensively, can help. It's not just a little bit of exercise, it's quite a lot of exercise, really? Probably every day. Yeah.
What, like cardio or strength or both?
Cardio, strength, both. But it has to be probably more intense than your average member of the population. So you have to get quite tired. The typical recommendation that is given, as you know, is 150 minutes or 30 minutes per week, 5 times. So exercising 5 times a week, at least 30 minutes. The intensity has to be strong enough that you can't quite speak in full sentences. So if you're speaking in full sentences with someone, you're not exercising quite intensely enough. So you have to catch your breath.
That's why I never get people who go in running clubs and can chat the whole way through.
Yeah, then you're not running fast enough. So, and obviously there's weight training as well. It's recommended a couple of times a week as well to help.
And in terms of diet, like there are all sorts of wild claims out there that, if you go on the keto diet, you'll stop feeling depressed. And there is evidence to suggest if you're intolerant to stuff or, gluten can make you feel a certain way.
So I think there is some evidence that the diet can make a difference. There's Chris Palmer, who wrote the book Brain Energy. whose theory about ketogenesis promoting mitochondrial rejuvenation and trying to therefore provide more energy to the brain, and that just seems to help a lot of patients. The trouble is things like a ketogenic diet, they might work, and sometimes I do recommend it. The problem is that society is not designed for it. So if you go to a restaurant, you might find a vegetarian option and you might find a vegan option even, but you're not likely to find a keto option. So what you end up having to do is you need to be someone very structured that can prepare meals in advance, have very clear menus and ideas as to what you're going to do. Because wherever you go, you will not find your keto diet options. It's a very difficult thing to maintain. And if you combine that with, for example, something like ADHD, where you struggle to organize yourself, then having to prep the meals for your week and never being able to, go to a restaurant because you're not going to find the food that you need there, is difficult. It's very difficult. So I have recommended diet changes for my patients, and quite often what you see is that they don't take them on. So it can help. There is good evidence. It seems exciting. However, it's very difficult to put into practice because society is just not designed for that.
Unfortunately.
Yeah.
I'm actually experiencing that myself because I'm on a very specific diet for gut health reasons, a bit keto-like, and as you say, it's really, really hard to actually stick to. So that unfortunately doesn't make it easier for anyone. But I'm curious to know, I know you're very active. I know you take your health seriously as well. What are the things that you personally try and do on a daily basis to kind of keep your mind in shape? Because you've got long days, you're dealing with people who have really significant issues. I guess you've got the pressure of having to make the right choice, and that is no small thing. That's giant every day that you have to deal with. So I guess, what do you do to sort of get through that on a daily basis, basically?
Again, over time, you realize that the answer is boring. The answer is your routine. You need a good routine that works and that functions. So for me, it's every day, wake up and do an hour of exercise. I like doing running and CrossFit. I think that has to be there. And then you have to combine that with a regular bedtime.
Yeah.
So about a quarter of the population never go to bed at the same time. So you need to go to bed at the same time that allows you to have enough sleep to then be able to wake up and do that. That's very basic, and that's a difficult thing to achieve, actually. You might have young children that wake you up. You might have a job that keeps you up till late. But that is essential for me. So I have to go and get, sadly, I only get about 6 hours. I've tried everything and I can't get more than 6 hours. But you should get at least 7 to 8 hours ideally. Then, yes, exercise, and then have a very healthy diet. And what that means, I think the most reasonable explanation I've seen of that is to avoid ultra-processed foods. Good book by Chris Tolkien about avoiding ultra-processed foods that generally you pick up and they live in a box and they have more than 5 ingredients, generally tend to be ultra-processed. So just buying whole foods that you're going to cook, process and eat yourself. That's quite time consuming, but I've seen it to be very helpful. If you do that, you tend to avoid things that are high in sugar, high in preservatives and other things, and then you tend to feel better. So yeah, if it's in a box and it's got long life, try and avoid it and just eat healthily. And then just establish a routine that you find is helpful and that it is sustainable. So whatever it is that you're going to eat, try and make sure that you can eat that regularly and that you're going to enjoy it, because otherwise you're going to do it for a couple of weeks and then you're going to then break down and do something else instead. So yeah, for me, it's been regularity, having things that you enjoy that you can incorporate into your life, like exercise and a good diet, and obviously spending time with family, friends, and being in a job that I really like. I mean, that's very helpful.
You also have a big passion of yours, which is kite surfing.
Yeah.
You didn't mention that one, but that I guess comes into it as well, because you know, it's important to have your own sort of interests and motivations. And is that for you a way to unwind when you've been feeling perhaps stressed at work, to just get out there?
Yeah, well, I think, as you once said on the beach, there's nothing relaxing about kite surfing.
I think witnessing you on an England beach, you know, in January, and the kite sort of, it's the taking off bit. I don't know how you describe it, but you have to kind of get some momentum. Someone has to help you. It's quite a, it's quite a commitment.
Yeah. Yes, I think for me personally, I think one of the things that I found that helps me is to have more fun. And I think for me, kite surfing is that. I guess, you know, the whole medical school and specialty training and all of that, it's quite demanding, quite intense. And then you do miss out on fun. And then you have young children, and then you have to do all the, you know, it's tough as well. So yeah, in the midlife, you then find that you would like some more fun in life. And for me, yeah, kite surfing would be, yeah, the thing. You know, I think it's amazing. It's a great sensation. I can't include it in my list of recommended well-being activities or good for your health or anything else. But
are there any studies?
It's certainly fun.
It's definitely healthier than, you know, buying expensive cars or something in your midlife.
Well, it's cheaper as well, so yes.
Jorge, thank you so much for coming on. It's been a pleasure speaking to you, and you know, the work you're doing on a daily basis is truly inspirational. And you know, I hope that more sort of clinics will take on the work that you're doing at Springbank and use that and sort of adopt that as well, because it sounds like it's very much needed in the UK. For your private practice, where can people find you if they're interested in booking an appointment?
Cambridge Psychiatry. Just Google Cambridge Psychiatry and .co.uk. Yeah.
Amazing. Thank you so much for coming on.
Pleasure. Thank you very much for having me.